Our speaker tonight comes to us from Cleveland Clinic. Dr. Philip Schauer is Professor of Surgery at the Cleveland Clinic Lerner College of Medicine, Chief of Minimally Invasive General Surgery, and Director of the Cleveland Clinic Bariatric and Metabolic Institute. Dr. Schauer's clinical interests include surgery for severe obesity, minimally invasive surgery, and gastrointestinal surgery. He has performed more than 5,000 operations for severe obesity. He has authored more than 200 scientific papers, editorials, textbook chapters, abstracts, and video productions, and is editor of the textbook Minimally Invasive Bariatric Surgery. Please join me in welcoming Dr. Philip Schauer to give his presentation, The Obesity, Diabetes Threat and the Rise of Surgical Treatment.
Obesity in the United States and many other countries has come to this extent. This is a young man who we think, according to records, was one of the top 10 heaviest people in North America. He weighed over 477 kilograms, or more than 1,050 pounds. His body mass index was 120. And just to give you a sense, a body mass index of 20 is normal. His was 120. So a huge man in his early 20s. And we used to think that this was an oddity, an extreme situation. But I'm showing this because this is becoming common and common every day. In fact, not too far from the Cleveland Clinic are at least half a dozen nursing facilities that specialize in giving care, custodial type care, to people of this size, who are 800, 900 pounds, who are in their 20s and 30s, and have basically been institutionalized because they are so heavy they cannot take care of themselves. So this is the extreme direction where this incredible epidemic is headed to. Now, fortunately, this gentleman has had quite a good result. He has gone through actually 3 stages of surgery. He is now close to 300 pounds and has done remarkably well. But I point this out to show you how extreme this disease can be. And we have to think of obesity not as a character trait or a personality disorder or a built-in weakness, but it is a disease. And we know that it is a major cause of many other modern Western diseases. You can see this huge list here of the associated conditions from top to bottom. Number of CNS problems, migraine headaches, pseudotumor cerebri, sleep apnea, a lot of breathing problems, asthma, of course cardiovascular disease, disease of the liver. In fact, fatty liver disease is becoming one of the most common liver conditions, leading to cirrhosis and liver transplant in the Western world. Other conditions, metabolic syndrome, diabetes, numerous orthopedic problems, problems with fertility. Obesity is a major cause of infertility in both men and women. And this is only a partial list of some of the problems. We tend to focus on those that are considered part of the metabolic syndrome, cardiovascular disease, hypertension, dyslipidemia, and type 2 diabetes, because those are the most lethal and the ones that bring the greatest problem. I'll be focusing on those shortly. Obesity is very costly. This is data from a 2009 study. The medical costs of obesity in 1998 in the United States, $78 billion. In 2008, that number more than doubled to $147 billion. The increased prevalence of obesity was the major driver of this. So it's an astounding cost factor. Diabetes is also a major problem, and we think diabetes is closely linked to obesity. In fact, we call it the twin epidemic of obesity and diabetes. Diabetes is also a very debilitating chronic disease. And this graph gives you a sense of how the disease progresses and how it's managed. When diabetes is diagnosed, patients are generally started on aggressive lifestyle management, diet, exercise, but ultimately they need medical therapy, drugs, oral agents initially, then insulin. And unfortunately, even despite this type of therapy, most patients go on to progression of their disease, such that 9, 10 years into the diagnosis, they're already developing secondary complications, such as neuropathy, nephropathy, kidney disease, cardiovascular disease, heart attacks, and stroke. So even though there are medications that can improve the condition, still most patients will progress and develop severe complications. They will die prematurely, estimated 10 to 15 years shorter lifespan, and before they die, they will likely have a major disability. And a lot of this is driven by diabetes. Diabetes is the leading cause of blindness, renal failure, and amputations. In the United States, it's a major cause of heart attack and stroke. And while we've made major progress over the last several decades in reducing death related to cancer, cardiovascular disease, and stroke, death-related diabetes is actually worsening in a very rapid rate. So this is a big, big problem that's going to be with us for many, many years to come. And diabetes, independent of obesity, is extremely costly. The economic cost of diabetes in 2007 was $174 billion. It's estimated that the health cost per individual, per patient with diabetes, is about $11,000 a year. So an amazing cost problem. Now, you can trace the obesity epidemic, and this is data from the U.S. CDC, or Center for Disease Control. You can trace the epidemic, and I apologize, this slide's a little fuzzy, to about the late 60s, early 1970s, when you can see that the percentage of individuals who are overweight and obese begins to rise. Late 60s, early 70s, and you see very progressive increase up until where we are today. So it's a relatively new epidemic. And this is the epidemic of diabetes in the United States. And you can see here it's about a decade or so behind the epidemic of obesity, rising in the late 90s and escalating dramatically over the past decade and continuing to increase over time. This graph, I think, very nicely illustrates in the U.S. the prevalence of obesity and diabetes state by state. And you can see, each of these colors represents a higher percentage of obesity and diabetes. And you can see that very rapidly, within a few decades, state by state, dramatic increases. Again, this is within a generation. This is not multiple generations, but within one generation, such a dramatic, overwhelming increase in this problem. And it's going to get worse. This is the estimates for the next 20 to 30 years. And although the United States is leading this effort, many other Western countries, UK, Australia, Brazil, many others are following closely behind. So this is going to be a staggering problem to be able to manage all of the health consequences, reduce productivity, and costs of this enormous problem. This is a world map of the countries related to their prevalence of diabetes. Again, the darker, the higher the prevalence. So here, this sort of dark orange, 14 to 20%, means 1 in 5 of the population has the disease. And you can see in the U.S., pretty high, Mexico. But look where it's the darkest, the highest prevalence in the world is where we're sitting right now, in the Gulf region. Dr. McClendon mentioned earlier that in this region, Abu Dhabi is the number 2. We think Kuwait is probably number 1, but it's only because these countries have good records. Some of the other neighboring countries are probably just as bad, but they don't have as good healthcare records. So it's an astonishing problem right here, and it's also believed to have occurred, very, very rapidly, just in the past 1 to 2 decades. This graph very nicely shows the relationship between the rate of obesity, the percent of population that has obesity, and the percent diabetes. And if you look at the countries in the world that have the highest combined prevalence of diabetes and obesity are right here. Saudi Arabia, Kuwait, Bahrain, and right up there with good old USA. So astonishing relationships. Now this is some data from this region. Dr. Kothar Hajat was kind enough to share this with me. This is obesity and diabetes prevalence here in Abu Dhabi. This is based on a recent, very comprehensive population survey, and they found that the adjusted for age, 41% of the population is obese, another 34% are overweight, so that 75% of the citizens of Abu Dhabi are either obese or overweight. And then when you add diabetes, that mix, 24%, so almost 1 in 4, almost 1 in 4 adult citizens have diabetes. And you add those that have prediabetes, almost half of the population either has diabetes or prediabetes. And you mix in with that hypertension and dyslipidemia, this is an enormous perfect storm for a disaster heading this nation and many others down the road. This is a complex slide, but I wanted to share with you some other alarming statistics at how effective they are controlling. And this is not unique to Abu Dhabi. I can show you similar data for the US. We're not very good, despite great health care, great drugs, we're not very good at getting patients under control. That is, getting their blood sugar to a good level to prevent the progression to devastating disease. So focus on this right here, well-controlled diabetes in males and females. So less than 20% of the population who have diabetes are well controlled. That means 80% are out of control. That means 80% are going to progress and develop these horrible complications. And moderately controlled, very small percentage as well. So very alarming statistics that are very sobering indeed. So what are the solutions and how are we doing? That's really the focus of my talk, the rest of the talk here. Now I want you to think of 2 categories of solutions. There's the prevention side and there's the treatment side. And of course, the long-term solution with any chronic illness is trying to prevent it, okay? I'm not going to talk too much about that, primarily because, not that it's not important, it's critically important, but this problem is so enormous that it's going to take generations to prevent. People compare this to cigarette smoking, which I think is a fair analogy. In the US, it took, and it's still taking, 3 or 4 generations to really address that particular problem. And obesity and diabetes are overwhelmingly more complex than cigarette smoking. So prevention is going to be a generational solution that's going to take decades and decades. In the meantime, we've got to focus on individuals that have the problem and how are we going to treat the problem to minimize as much as possible the progression to complications. So let me just give you an example of an individual. This actually was a patient of mine, a fairly typical gentleman who is seeking medical treatment for his many conditions. And as you can see here, he's got many of the comorbidities of obesity. He has hypertension, elevated cholesterol, he has diabetes, he has non-alcoholic steatohepatitis, so this is a pre-cirrhosis condition of his liver. He has obstructive sleep apnea, very common in patients who have obesity. He has left ventricular hypertrophy, which is thickening of the heart muscle due to hypertension. So the modern way of, or the current way of treating this individual is he would be going to 4 or 5 doctors. Each doctor would focus on one of these conditions and treat that specific condition. Okay? And there would be very little attention to the central problem. And the central problem is in the center of this photograph is this obesity. Now, an alternative strategy, which I will propose to you tonight, is to focus on the central problem, then these problems will correct themselves. So focus on the obesity and these problems will be self-corrected. So how do we do that? Well, this is sort of the standard treatment algorithm for how we handle obesity, and it's based on a stepwise approach based on the severity. And we use the body mass index as a crude measure of the severity of obesity. So individuals who have a normal body mass index, a normal body weight, 20 to 25 BMI, above 25 become overweight, above 30 you're obese, above 40 you would be considered severely obese. So at the lower BMI level, BMI 30 or say 25 to 30, these strategies, lifestyle modification, diet, physical activity, are the mainstay of treatment and can be effective in individuals with relatively, mild obesity. As you go up higher, the severity increases and the refractoriness to this sort of lifestyle modification strategy increases as well. So pharmacotherapy should be introduced at the higher BMI, let's say BMI of 30, 32, 35. Unfortunately, there are no effective drugs yet. And although the last 30, 40 years has been intense research, we have yet to produce an effective drug for weight loss. And then finally, we talk about surgery when we get to the extremes, a BMI of 40 or greater, which is roughly about 50 kilograms or 100 pounds above ideal body weight. And this is where these other strategies really have not been shown to be effective at all in the higher body mass index group. Now, let me just share with you what you can expect in terms of results, and particularly for the people that need the treatment the most are the higher body mass index patients, BMI of 40 or greater. Unfortunately, this is an example of a very aggressive weight loss strategy using diet, exercise, behavior modification, and drug therapy. In this case, the drug was sibutramine, which is no longer available because of severe side effects. But you can see, and this is a group of very heavy individuals, their weight was 145 kilograms, so they were about 300 pounds or so when they started, and at the beginning of the study, after 21 weeks, had a pretty good drop off in their weight. But the problem here is that despite therapy, despite continued therapy over the years 2, 3, and 4, most of the patients regain much of what they have lost. So at the end of the 4-year period, the net weight loss is about 10 kilograms with a very aggressive diet program that is supervised. So 10 kilograms, 20 pounds in a person who's 300 pounds will produce some benefit, but you're still left with a very severely obese patient. And this is one of the best studies. So there are no studies showing significant efficacy for severe obesity, going beyond 1 or 2 years. It just doesn't exist. We just don't have any effective therapy, unfortunately, other than surgical therapy. And when you add to the obesity all the other medical conditions, the current strategy has been a strategy of polypharmacy. Now this woman, she's not that severely obese. Her BMI is about 35, so she's about 60 pounds overweight. She has diabetes, high blood pressure, dyslipidemia, sleep apnea. And you can see this is her medication list. Oral medications, inhaled medications, applied, injected. This is her list of medications she takes daily. Okay, this is an article out of New York Times. Now this is an extreme exaggeration, but this is the endpoint, or I should say the limitation of medical therapy. How could anybody take all this medication every day? It's a strategy that to me does not make any sense, but that's the strategy that's being pushed. You just give more medications until you reach your target endpoint of blood pressure or cholesterol or blood sugar. And unfortunately, this is a very unrealistic strategy for most people. So let's talk about another completely different strategy, and that is surgery. And for many of you, this is going to seem quite radical. I mean, after all, surgery is dangerous and can cause complications. But I will submit to you that with modern advances, the risk of surgery have come way down and the efficacy is quite remarkable. So who should actually get surgery? And these are a list of qualifications for surgery. First of all, the individual, you must be severely overweight. A body mass index of 35 or greater if they have associated comorbid conditions, or a BMI of 40 or greater even if they do not. They must, of course, be an acceptable operative risk. They must have tried other measures, diet, exercise, before they go to surgery. That's just common sense. They should be psychologically stable. They should be well informed. And they should have no active psychologic disorders that are not well controlled. And they should have no substance abuse problems ongoing. These are the three most common procedures I'll just talk with you about briefly that are performed in the U.S. and for that matter throughout the world. To the left is the gastric banding procedure, and all these operations involve operating on the stomach and the intestinal tract, and the goal is not just to reduce the capacity of the stomach, but actually reduce appetite and enhance the opposite of appetite, which is what we call satiety. Enhance satiety, the sense of feeling full after a meal, and reduce appetite. That's how these procedures work. So the gastric banding operation, which is the least invasive, involves placing a silicone band around the upper stomach. It's stitched in place, and the band is connected to some tubing which goes to a little port that's implanted in the skin of the abdomen. And fluid can be placed through a small needle into the tubing, and this tubing will make this ring much tighter. And I'll show you a little video in just a minute. And by making this tubing tighter, it reduces the outflow from the stomach pouch into the remainder of the stomach, and that causes a heightened sense of fullness. So a relatively small meal, just a few bites of food in fact, can make an individual feel as if they had a large meal and they're done. So they lose weight because they decrease their intake of calories. The procedure to the far right is very similar as well. This is called the sleeve gastrectomy. It accomplishes the same thing, except that instead of putting a band around the stomach, we're actually removing about 70 to 80% of the stomach. We're making the stomach smaller. So I tell my patients their stomach is going from the size of a football, an American-sized football, when it's fully expanded, to the size of a banana. So it's a very radical reduction in the size, okay? And then the procedure in the middle is the most popular operation, actually, the Roux-en-Y gastric bypass. It's the most popular because it's the most effective. The stomach is made even smaller. We staple the upper part of the stomach. We make a stomach pouch that's about the size of a golf ball, so even smaller. And the intestines are divided, and this far end is reconnected up here, and this end is reconnected here. So food's going into the pouch, fills the pouch up, patient feels full, food empties and goes down here and is digested. We're completely bypassing the remainder of the stomach, upper part of the intestines, okay? So those are the three popular procedures that we have today, the most effective being the gastric bypass, next the sleeve gastrectomy, and next the gastric banding procedure. I'll show you just a real quick video to give you a little better sense of the procedure. And one of the major advances has been the development of minimally invasive surgery. So instead of making a big incision, very small incisions can be made in the abdomen. These are less than an inch, about half of an inch in size. Patient is fully asleep, of course, and through these little cannulas are placed operating instruments. In this case, this band is placed inside the abdomen. It'll be placed around the upper stomach. And you can see inside the band is a reservoir, and the reservoir can be expanded by adding fluid through this tubing here. So the beauty of this procedure is that we're not disrupting the anatomy at all. There's no stapling or cutting of the intestinal tract. And this is just a placement of the small port that is placed below the skin. And through that port, a small injection of fluid is placed. And you can see here the food bowl is coming down. It's stalled right here. And this sends signals to the brain that the patient's full. And so they're likely to stop eating because they reach that point of satiety. Now let me just show you the gastric bypass procedure. And this procedure is also performed laparoscopically through these very small incisions. Usually patients will be in the hospital 1 or 2 days. They will take off about 2 weeks from work. They're back to work, and they progressively lose weight for about 12 to 18 months until they get to their target weight. So with the gastric bypass, you see this is the upper stomach. We staple it right here, creating this golf ball sized stomach pouch. And the intestines is divided, and this far end is brought up and connected to the pouch right there. And then this end down here is reconnected right here. There we go. In the gastric bypass procedure, which is the most effective, there we go. You see the food go down here, and then it mixes with the digestive enzymes, the bile and the enzymes further downstream. Okay, and I'm going to skip this video just for time, but this is the sleeve gastrectomy, and this procedure, as I mentioned before, involves stapling the stomach. There's a little tube in place as a sizer, stapled alongside that tube, and this part is removed, so you end up with a very narrow, skinny stomach. Okay. As I mentioned, one of the major advances, one of the reasons why bariatric surgery has become so popular in the United States and many other countries is because we've been able to eliminate this big incision here. So these operations are performed with very, very small incisions, and that has dramatically reduced the postoperative pain, the recovery time, many of the potential complications, and it's even reduced the risk of dying from the surgery quite dramatically, such that these procedures are relatively low risk for the majority of patients who have these operations. Here's another example. When I started my career, this is how we performed these operations many years ago in the early 90s. These big retractors, big incision in a large patient. Of course, it's long, but it's also very deep. And the risk of problems like hernias and infections and pain were very, very large. And then the modern era, very small incisions here, rapid recovery, patients get back to work quickly and enjoy the benefits of their weight loss very rapidly. Now, these are some statistics from a publication in the American Journal of Medicine several years ago, giving you a sense of what the expected weight loss is. And for gastric banding, which is the least invasive, patients tend to lose a little bit less than half of their excess weight. So if they're 100 pounds overweight, they tend to lose about 50 pounds. With gastric bypass, they tend to lose about 65% or so of their excess weight. And I didn't mention this procedure because it's not performed very commonly. The biliopancreatic diversion procedure, patients lose even more weight, but it's a much more aggressive operation that has higher complication rates. And this is the overall mortality risk, the risk of dying within 30 days of the procedure. And these are quite low, and they've actually gotten better even since this publication in 2004. So 0.1% means 1 out of 1,000. 0.5% is 5 out of 1,000, and then 1% is 1 out of 100. Okay, and this shows you the overall risk, the percentage of patients who actually have complete resolution of their underlying condition. So diabetes, more than 75% will go into complete remission. That is, their blood sugar is normalized and they don't require medical treatment, insulin, pills. And the same for hyperlipidemia, or elevated cholesterol, high blood pressure, sleep apnea. All of these are dramatically improved following surgery. Now, you might ask yourself, well, that's great news, but how long does this last? Some people might have the surgery and regain all their weight in a few years. Well, that can occur, but it's quite rare. And here's a very, very important study, looking at the effects of surgery 15 years and beyond. And there was about 2,000 patients who had various operations, gastric bypass, vertical banded gastroplasty, gastric banding, compared to a very similar group that were matched who had medical treatment of weight loss. And the average patient in this study weighed about 300 pounds, so about 140 kilograms or so. And you can see at the start of the intervention, there was a significant weight loss. This is measured in terms of percent of initial body weight. So you see very dramatic reduction after surgery. But the point I'm trying to make here is that, and even though there was a little bit of weight regain in the surgical patients, most of that weight loss was maintained 15 years and beyond. And this is the real value of this intervention, is that it is quite durable. Now, this particular study, called the Swedish Obesity Subject Study, which was conducted in Sweden, began in the late 1980s, is now accruing the 20-year follow-up data, so 2 decades. And the data will be presented later this year, and it looks like in the weight loss for the surgical group will continue to be about the same, whereas in the medical group, essentially no weight loss over this time period. Now, when you look at these figures, the results are quite amazing when you compare with the alternative weight loss strategy of diet, exercise, and drug therapy. And here's a study that actually does that. This is one of the very best weight loss studies comparing lifestyle placebo versus lifestyle plus orlistat, which is the only FDA-approved drug available today. And you can see in the first year, with an aggressive diet, this is a very low-calorie diet, you can see some significant weight loss, but within 2 years, they've gained back half of the weight. And these studies generally only last 2 years because most patients regain all the weight within 3 or 4 years. Now, it's important, I said all these great things about surgery. These operations, even though they're minimally invasive, they can still lead to complications. I'm not going to have time to go through all of these, but things can happen in the first few days and weeks, like bleeding and infection. Problems with the stapling can occur. And then there can be some late problems. Particularly hernias can develop, although they're much less common because the incisions are so small. Patients can develop vitamin and mineral deficiencies. They can regain the weight, but it's not very common. so there can be some late problems as well. But in general, these complications, the rate of the complications has diminished quite dramatically, and the severity as well. And this graph, I think, very nicely shows you the overall effect on all those conditions I showed you at the outset following surgery. And every one of these is supported by many studies in the medical literature suggesting that these conditions go away or improve. For example, sleep apnea, 75 to 98% resolution. Fatty liver disease, 90% improved, 37% resolved completely. Hypertension, 50 to 90% reduction. And diabetes is probably the most outstanding result or example, 83% remission following surgery. They're quite dramatic. So it is so dramatic in treating diabetes that surgery is now being considered more and more a specific treatment for diabetes. Here is a study published a few years ago on severely obese patients who had diabetes and had surgery. And these are the various operations right here: gastric banding, gastroplasty, gastric bypass, biliary-pancreatic diversion. And this line shows you the percent of resolution of diabetes, anywhere from 55% up to 94% after these procedures. Very dramatic. And these operations have important effects on these other cardiovascular risk factors that are commonly associated with diabetes and obesity. So hypertension, 68% resolved or improved. Diabetes, 75%. Dyslipidemia, 71%. So it means when it's resolved, it means it's normalized and they don't require any medical therapy. And this is an example of a young woman who had surgery. It was not severely obese. Her body mass index was only 33. Here she is in a preoperative image, but she was on more than 200 units of insulin, meaning she was injecting herself 4 times a day, taking 3 oral pills for diabetes, 2 pills for hypertension, 2 pills for her cholesterol, and also having a breathing machine for sleep apnea. And this is about 3 years later, and her weight is perfectly normal, and she's on no medications for her diabetes. So we're beginning to think about these operations, not just for severely obese diabetics, but for diabetics who are just modestly obese. And probably the most important impact of these operations is the effect on the lifespan. And here's an example. There's about 9 or 10 studies looking at the effect of these procedures after many years of follow-up compared to patients who didn't have the surgery. And this is the mortality reduction, anywhere from 30 up to 80% mortality. So these operations are actually not only resolving obesity and diabetes, but saving lives or expanding or improving their longevity. And these procedures have gotten safer and safer. And this is because, number one, they're much less invasive, and number two, much better training in specialized centers who concentrate and focus on these surgeries. This is a recent publication in New England Journal of Medicine of a very large study that evaluated the overall risk of surgery, and the 30-day mortality risk was 0.3%. Okay? That's comparable to the mortality risk of a hysterectomy, of gallbladder surgery, of appendectomy. So very common procedures that are done every day. And the overall risk of major complications was about 4%, which is fairly respectable. And just to compare the mortality risk of surgery, and again, I'm showing this because many people think that this is radical surgery, that it's dangerous. But a 0.28% risk is about the same risk as a hip replacement, and it's 10 times lower risk than coronary artery bypass for somebody who's got a blockage in their coronary artery. So it's 1/10 the risk, but it actually is much more effective in terms of increasing longevity than coronary artery bypass, believe it or not. Now, many organizations, many scientific organizations have endorsed bariatric surgery, and they believe that patients should have access to the surgery if they qualify. This is NIH in the United States, CMS, which runs Medicare, in many professional organizations, the American Diabetes Association, American Medical Association, in the UK, the National Institute for Health and Clinical Excellence, NICE, and many others endorse bariatric surgery as an effective treatment. And this is very recent from the International Diabetes Federation, which is probably the most preeminent professional organization promoting diabetes management. Suggests that patients that have a BMI of 35 or greater with diabetes should have access to surgery. And even patients with lower BMI, as low as 30 to 35, if their diabetes is not well controlled with medical therapy, they should consider surgery. And some ethnic groups, particularly, and this is relevant here, people from Asia seem to be more predisposed to the complications of diabetes. So they should be considered for surgery even at a lower body weight, a BMI of 27 to 32, which is about perhaps 25 to 30 pounds overweight. Now, before I finish, I'd like to just share with you what's in the pipeline, because I think we're not done with surgery in terms of innovation. I think the next decade is going to be quite exciting because new procedures are going to emerge, which are going to be even less invasive. We're not going to be able to even call them surgery because there's no cutting involved. These will be minimally invasive procedures. Most of them will be delivered through the GI tract, just like an endoscopy. Here's some examples. The one to the left right here is called gastric plication. This is a procedure. This one is still done with laparoscopic surgery with the small abdominal incisions, but instead of cutting the stomach, we're just folding it in. So your stomach is still there, but we're reducing the stomach volume by folding in the outer part of the stomach. You can see the outer wall folded in right here. So here, there's no cutting or stapling, so the risk of bleeding or infection should be many, many times less, okay? And then over here is a procedure where we reduce the stomach volume totally inside the stomach through a endoscope with a special stitching device attached to it. So we can make the stomach smaller without any cutting, without any surgery, and this can be done in an endoscopy suite. Now this is experimental right now, but perhaps in the next 3 to 5 years, a procedure like this will be available. So imagine a person going into the doctor's office in the morning, leaving 2 hours later, going back to work. No one knows they had any procedure done, and over the next 6 to 9 months, they're losing weight, and it's staying off permanently. Imagine that. I think the reality will be fairly soon. Here's another really exciting concept. This is a sheath that is inserted through the stomach and attached to the duodenum, and it lines the small intestines, and it prevents calories from being absorbed into the GI tract. It just passes on through. And this will reduce the absorption of calories into the body, and patients will lose weight because it's not effectively absorbed. So this is a new concept that's also being studied throughout the world and perhaps may be available in the next 3 to 5 years. And again, this is without surgery. It's a procedure that looks like it may be quite effective. So as I conclude, I wanted to end, I showed you a lot of statistics, a lot of data, but I sort of wanted to end with real people to give you a sense of the impact of weight loss on the lives of real people. And here's an example. This fellow, I thought it would only be right that I showed you how he turned out after he was treated with a more modern concept of disease management, treating the central problem, his weight. This gentleman had a gastric bypass well over 10 years ago, actually. And he was quite heavy. His body mass index was over 50, which means he was more than 150 pounds, more than 75 kilograms overweight. And there he is. This is about 5 years after surgery. dramatic weight loss, and you can just see. You don't need to be a doctor to know he's much healthier. And I can tell you that his diabetes, his hypertension, his cholesterol problems were all dramatically improved and in many cases resolved completely. Now I know what you're thinking. Who's this? Right? It's not his wife, but it's okay. It's my nurse, Laura. And she's also a successful 15-year graduate of gastric bypass. And Laura, at her peak weight, was about 330 pounds. And 10, 15 years after the procedure, there she is. And let me just share with you some other patients before and after. I mean, you can just see. Now, you can see this on modern TV. And there's these popular TV shows, Biggest Loser and so forth. But the difference is, and they never show you on the TV show what they look like 5 years later. What I'm showing you are images that are 3, 4, 5 years after the procedure, okay? Because the weight loss is kept off and maintained, and that is the difference with a surgical procedure and a diet and exercise program. And it's not just the health, it's the effect on the quality of life. And this woman here, so large, too embarrassed to really participate in her daughter's wedding, but had surgery, and there she is, enjoying many of the important things of life where she probably could not have enjoyed as much in her former size. So a big impact on not just health, but quality of life. That's really what it's all about. So in conclusion, let me just share with you that we're in the midst of an enormous epidemic of obesity and diabetes, and it looks like there's no end in sight. Governments, countries need to focus on this problem much more and develop important strategies for prevention. But even with intense focus on this subject, many believe that it's going to take years and years and years. In the meantime, we've got to address the problem and those people that have the disease and provide them effective therapy. And it has to be therapy that's going to be effective for many, many years. And so for some people who are struggling, surgery will be an important option. I showed you that it can be safe, relatively safe, it's effective, it's durable, and has a remarkable impact on the lives of people. And it's exciting that new procedures will emerge in the next few years that will probably be even more effective and safer. Finally, I just want to acknowledge my colleagues at the Cleveland Clinic. These are the physicians and surgeons I work with on an everyday basis. Dr. Karen Cooper and Dr. Derek Seaton are medical specialists, and the rest are surgeons, Dr. Chan, Dr. Bretthauer, Dr. Crow, Dr. Rogula, and myself. I'm lucky to be able to work with these people in a world-class institution.
I suffer from type 1 diabetes, insulin dependent. And I noticed earlier that you referred to type 2 diabetes mellitus. And then you gave an example of a lady with type 1 who you claim was cured, and she stopped taking her insulin. As a type 1 diabetic, I find that difficult to understand, because when I became a diabetic 20 years ago, I wasn't obese. I've become obese at the front here, probably with age more than anything else. But I really find it difficult to understand how the weight loss, and secondly, just before I finish, once you've finished with the surgery and once somebody's got down to their normal BMI weight, do you then release the stomach again? Do you let it open, or do you keep it banded in perpetuity?
Great. So great question, and thank you for bringing up the issue about diabetes, because I probably should have explained it a little bit better, that there are two types of diabetes, type 1 and type 2. Type 2 is a diabetes that's mostly associated with obesity, okay? And with type 2, which represents the majority of individuals with diabetes. For example, the United States is estimated there's about 20 million people with type 2 diabetes. There's about 50,000 that have type 1 diabetes. So big difference, okay? With type 1, which usually occurs in childhood or adolescence, it's thought to be caused by perhaps a virus or an autoimmune disease where the cells that make insulin, the beta cells of the pancreas, are destroyed. So in type 1, the pancreas, the body does not make any insulin whatsoever. So patients who have type 1 must have insulin delivered to them. Okay, now, the woman I showed you was a type 2 diabetic, okay? Now, she was on insulin, but many type 2 diabetics need insulin as well. As the disease progresses, what happens is they start out with a normal population of beta cells in their pancreas. But over time, the beta cells die out, okay? And they become dependent on insulin, okay? So both patients with type 1 and type 2 may require insulin. But individuals with type 1 must have insulin because they make no insulin. Now, unfortunately, one of the side effects of insulin is weight gain. Insulin is a growth hormone. And so many folks who've had diabetes type 1 for many years will have trouble with their weight. They will gain weight because of the insulin over time. Now, these operations that I mentioned to you, the primary focus was treating obesity and type 2 diabetes. However, some type 1 diabetics may benefit. Now, these operations will not cure type 1 diabetes because those patients will not make insulin, but it can definitely help them with their weight, and it can help reduce the amount of insulin that they do require. Okay? Now, your second question was, after the operation is done, like the banding, for example, do you let it out afterwards? And the answer, unfortunately, is no. If you undo the and all these operations can be undone, can be reversed, essentially. If you take the band out or let the fluid out of the band, almost always the weight comes back, okay? So these operations are meant to be permanent changes to cause permanent weight loss.
I assume that the best result will be on the non-insulin dependent diabetes, but what's the effect on, or what's the outcome on either insulin resistant or insulin dependent diabetes? That's the first question. The second question, you talk about the 70% cure/improvement, and that begs the question is, what's the ratio between cure and improvement? And improvement, what kind of improvement? Can you quantify that improvement?
Those are excellent questions, and it sounds like I'm talking to an endocrinologist. Are you an endocrinologist, sir?
I'm a radiologist.
A radiologist, okay, all right. Those are excellent questions. So it turns out that the longer a patient has diabetes, and the more progressive the disease is, the cells that make insulin gradually die out, and the severity of the disease is worsened. So when we intervene surgically, if we can intervene earlier in the time course, let's say within, 5 years, within 10 years of the diagnosis, then that thing we call cure rate, I think a better term for that is remission, okay? The remission rates are in the 75–80% range, okay? Individuals, though, that have had the disease for 10, 15, 20 years, they have very little beta cell function left. And by then, it's often too late for a cure. We can still improve their condition quite a bit, reduce their dependency on insulin quite a bit. In many cases, still wean them off insulin, but we don't get them off all their medications completely. So the earlier we intervene, usually the better outcome.
As impressive as your results are with curing obesity and diabetes, one of your earlier slides showing the rate of increase of diabetes both in the U.S. and around the world is astounding. And to think that humans have been around here for a few million years, and in the last decades, obesity has just become, it's unbelievable to see it go to 20 and 40%. Is it simply just an easy calories and avoidance of exercise, or do you have any inklings on some of the theories. I don't want to be what do you call a conspiracist, but any inklings on, are we doing other things such as with the refined foods affecting our gut flora, or the high fructose corn syrup, or other issues which maybe are underlying some of those diabetes, some of the weight gain, rather than
Right.
simply just calories and lifestyle?
Yeah, and I didn't really touch on that because that's the subject of not only an hour lecture, but many, many lectures. The cause of the obesity epidemic, and you're right, it's just a modern enigma. It really is, because it happens so rapidly, and there's some really smart people, scientists, devoting their entire lives to this subject, and there'll be a Nobel Prize someday on this subject. Most people who are well-read in this area seem to come to the conclusion that it is, like many other things, it's a mixture of nature and nurture. Okay, nature being a genetic predisposition. We know that there are certain ethnic groups, there are certain types of people that are predisposed to being very obese. There are some people who are protected against being obese. Many of us probably know of individuals that can eat all day long and not gain weight, right? So there's a genetic component to it, but you don't see an epidemic from a genetic cause rise in 1 or 2 decades. So that can't explain it. We know that the environment must play a major role, and there's many theories. We know it's a fact that the average activity level of humans has dropped dramatically. A lot of different reasons why that may be. We know that caloric consumption has increased. A lot of these are driven, we think, by economic forces. Food is much cheaper these days. It's one of the few commodities on the planet that has actually decreased over time in terms of cost compared to many other commodities and services that have increased over time. It's readily available, and the cheapest food is the food with the highest concentration of sugar and complex carbohydrates. So, that's just the tip of the iceberg of an explanation. We don't really know. We don't really know. That's why I said earlier that the prevention, which is the ultimate answer, is going to take decades, because we don't even understand the problem yet. And I think it's an oversimplification when one person stands up and says, I know what the problem is. It's fructose. That's what it is. I know what the problem is, that the kids are in the computer and they're not exercising. That's the problem. I know the problem is because Pepsi has a Coke machine in the kids' cafeteria. It's much more complex than that. It's socioeconomic forces combined with a genetic predisposition, and it's going to take some really smart, dedicated people focusing on this problem for decades to begin to make a dent, just to level off the growth. Okay, and we all know what the challenge of cigarette smoking was, and that take 75, 100 years, and still in the United States, 20% of Americans smoke. We went from 40% in the 1960s to 20%. And with intense public health, governmental intervention, we dropped that in half, but it took 75 years. So this one is going to be a much bigger scale problem, I think.